We're going to start out with a general review of pulmonary anatomy and pathophysiology, and this is a review from the pathophysiology class. And so hopefully none of this will be, stop the press's news to you. So then we're going to talk about pulmonary assessment and techniques, and those are what we're going to practice in the lab. And we're going to talk about PT exercise for people with pulmonary disorders and what the considerations are, of course, functional outcome measures, and all sorts of fun stuff to do in the lab. So the learning objectives that I have listed here, there are 2 pages of them. They're in the Canvas module, and they are for all of the sections of the PowerPoints. But I'm just going to list them all here to start with. So we want to identify the goals of pulmonary physical therapy, describe normal cough mechanism and factors which impair coughing. We want to demonstrate the principles and techniques for teaching breathing exercises according to the PT plan of care. Indications and contraindications for postural drainage. Those are all nicely listed in O'Sullivan. We want to demonstrate procedures, positions, and techniques of postural drainage, and that we're going to do in the lab. And apply knowledge of respiratory structure and function while performing select interventions for patients with pulmonary dysfunction. We want to be able to describe and perform the procedures and sequence teaching for a patient learning diaphragmatic breathing, glossopharyngeal breathing, and pursed lip breathing. We'll practice those in the lab. Describing normal and abnormal pulmonary wall mobility, expansion, and excursion. And we want to be able to perform pulmonary percussion techniques in a lab setting with instructor supervision, and perform the some other techniques, including assisted cough techniques and manual cough techniques, and normal and abnormal cough and sputum characteristics. It always comes down to sputum when you're talking about the respiratory system, doesn't it? So pulmonary anatomy, this is different cross sections of the lungs, but just as a refresher, the respiratory system is basically the mechanism by which we transport oxygen from the air into the blood and remove carbon dioxide from the blood. So of course we need oxygen for cellular metabolism, and carbon dioxide is a waste material resulting from that cellular metabolism. So basically, chemistry it always comes back to chemistry, doesn't it? Well, for me it does. You burn hydrocarbons in oxygen, and the byproducts are water and carbon dioxide. So the water goes to our fluid balance. The carbon dioxide participates in the buffer system to maintain our acid-base balance in one of the buffer systems, and it's excreted by the lungs. So if we're not, if the lungs aren't functioning right and we're not excreting carbon dioxide, that can affect our acid-base balance. So a lot of people with respiratory dysfunction live in a state of respiratory acidosis. That's not necessarily a good thing. Well, it's not a good thing, in fact. We like to avoid that. So of course, the respiratory system is the upper respiratory tract and the lower respiratory tract. The upper respiratory tract, we don't really, besides keeping the airway open, we don't really work with that much in pulmonary PT. But knowing what's going on in the lower respiratory tract is super important. So besides the mechanics of breathing, we're going to talk about the process of ventilation and expiration. So airflow during inspiration and expiration depends on a pressure gradient. So air always moves from a high pressure area to a low pressure area. And it's one-way flow. So either it's coming in or it's going out. You can't inhale and exhale at the same time, in other words. So if you're not blowing your air out, it better be coming in. Or you're not breathing. So you're either doing one or the other, inspiration or expiration. But if the atmospheric pressure is higher than the air pressure inside the alveoli in the lungs, the air will move from the atmosphere into the lungs, inspiration. For expiration to occur, the pressure has to be higher in the lungs than in the atmosphere. So the pressure changes in the lungs result from alterations in the size of the thoracic cavity. So as the size of the thoracic cavity decreases, the pressure inside the cavity increases. And when you get enough pressure to overcome atmospheric pressure, you exhale. That's expiration. So the sequence of events that happens is normal, quiet expiration begins with contraction of the diaphragm, which is the primary muscle of inspiration, and sometimes the external intercostal muscles. The diaphragm flattens and descends, increasing the length of the thoracic cavity. The external intercostals raise the ribs and sternum up and outward, and we'll look at the rib mechanics in a minute. And it increases the transverse and anterior posterior diameters of the thorax. So not only is the thoracic cavity getting longer, it's getting wider and it's expanding in an anterior posterior fashion. So anything that affects that is going to affect your respiration. So the increased size of the thoracic cavity results in decreased pressure because of those gas laws, which I don't expect you to know right now. But the increased size of the thoracic cavity results in the decreased pressure, and the ribs and the diaphragm move, and the attached parietal pleura pulls the adhering visceral pleura and the lungs along with it, so it expands the lungs. So as the visceral pleura moves outward, the elastic lungs expand, resulting in a decrease in air pressure inside the lungs. So at this point, the atmospheric pressure is greater than the intra-alveolar pressure, so air flows from the atmosphere down the airways into the alveoli, which is wonderful. That's what we want it to do. So the thorax and the lungs have to expand before the air enters the lungs. It's not the air entering that expands the thorax and the lungs. So we have to have that musculoskeletal movement and the organ expansion before the air can come in. So breathing requires physical effort and cellular energy. So during normal inspiration, the diaphragm and the external intercostal muscles relax, leading to a decrease in thoracic size. There's also elastic recoil of the lungs. So the decreased thoracic size combined with the natural elastic recoil of the lungs results in increased intra-alveolar pressure greater than atmospheric pressure, and therefore the air flows out of the alveoli into the atmosphere. Quiet expiration is a passive process and does not require cellular energy. So inspiration, yes, requires muscle contraction and cellular energy. Expiration is a passive process. Forced inspiration or expiration do require additional energy and muscular activity. So a lot of times someone who has pulmonary disease requires additional energy, additional cellular energy in order to breathe, in order for inspiration and expiration to actually happen. So that's kind of interesting, I think. So the different lobes of the lungs and lung segments, it's different from left to right, isn't it? And when we talk about postural drainage, we'll talk about what positions are going to drain what areas. So when we're looking at the surface of the body, which of course we are, because we're not going to do surgery, we're going to do therapy. The second rib indicates the carina, which is the little cross area of the bronchial tubes. The fourth to sixth rib anteriorly and the sixth to 10th rib posteriorly. That's the anatomy that we're looking for when we're looking for the lungs and the bronchi when we're looking at the surface. So respiratory muscles, if you remember, the diaphragm is the big one. The external intercostals lift the rib cage and expand it. The internal intercostals lower the rib cage and contract it. And internal intercostals are only used for forced expiration. External intercostals are used for relaxed or quiet inspiration, normal inspiration. The abdominal muscles, of course, are involved with forced inspiration or inspiration or expiration, and the sternocleidomastoid and scalenes. The accessory muscles, anything besides the diaphragm and the external intercostals, are considered accessory muscles. They're only used when necessary. So they're not used all the time. But when you have forced inspiration or expiration, and a lot of times with pulmonary pathologies, you have that, those muscles come into play. And we'll talk a little bit about that and how it comes into play in therapy. So the mechanics of ventilation, the ribs have to move. Remember how I just said that the ribs and thorax have to expand before the air comes in. So how is that going to happen? So it happens differently in different areas of the rib cage. So there are three different mechanisms. The pump handle mechanism, which happens in the upper anterior rib cage, if you want to think of it that way. The bucket handle, which happens on the lateral sort of middle rib cage, and the caliper, which happens in ribs 11 and 12, the false ribs. So we'll look at each one of those individual ones. So the pump handle motion during inhalation. So the pump handle, it's like it's lifting up and pushing down, lifting up and pushing down. So the sternum is kind of the handle, if you want to think of it that way. It occurs predominantly in the sagittal plane. So it's anterior expansion of the thoracic cavity. It elevates the rib cage and sternum, and the movement mostly occurs anteriorly in the sagittal plane. So those are the kind of the upper ribs that are doing that motion. The middle ribs have that bucket handle motion during installation. So the visual is the bucket handle goes up and out. The ribs elevate. The lower ribs have a more angled shape, allowing for more motion at the lateral aspect of the rib cage. And we'll palpate this on each other in lab. Each rib elevates and has a slight upward rotation during inhalation, during this bucket handle motion. The caliper motion, it's like the little tips of a caliper pinching together. You can imagine that the bilateral ribs 11 and 12 are your thumb and index finger pinching together. As you inhale, they move farther apart, so you unpinch. As you exhale, they pinch together. So inhale, unpinch, exhale, pinch together. And because, like with your thumb and index finger or with a caliper, the two tips aren't touching, those are only ribs 11 and 12, those ribs that aren't attaching to the sternum. So 11 and 12 do the caliper motion. The middle ribs that attach to the sternum do the bucket handle motion. And the ones that, the upper ribs, 1, 2, 3, 4, basically, do the pump handle motion, expanding the sternum anteriorly in the sagittal plane. So lung volumes and capacities. The one thing to think about is a volume is a volume measurement of something, and it's measured in milliliters or liters. And total lung capacity is usually about 6 liters or 6,000 milliliters. It's going to vary from person to person, of course. That's on average. Capacities are combinations of different volumes, if you want to think of it that way. And I have a slide that has the definitions of all of them. So when you inspire air through the nose or mouth, through all of the airways until it reaches the end of the lungs, basically, the movement of air at full inspiration, the lungs contain their maximum amount of air. So the volume of air at full inspiration is called the total lung capacity. And that is usually, on average, about 5 to 6 liters, or 5,000 to 600 milliliters. The total lung capacity is divided into 4 separate volumes of air. The tidal volume, and we'll talk about the definition of each one, the inspiratory reserve volume, the expiratory reserve volume, and the residual volume. So a combination of two or more lung volumes are capacities. So vital capacity is a combination of different volumes, and total lung capacity is a combination of different volumes. So that's kind of, you can tell the difference. Volume is one thing and a capacity is a combination of volumes. So the amount of air inspired or expired during normal resting ventilation is the tidal volume. So the tidal volume of air enters the pulmonary system. It travels into the respiratory units. It's usually about 500 milliliters. So a small amount of the total volume is the tidal volume going in and out. I find that interesting. And most of the average lung volumes are done in healthy young white males. So if you're not a healthy young white male, you're going to have different average volumes. Just FYI, a lot of research is done on those guys. The amount of inspired air that actually reaches like the very endy end of your alveoli is only about 350 milliliters of that total 500 milliliters. The remaining 150 milliliters remains in the airways and doesn't take part in the gas exchange, because there has to be, you can't just have a vacuum. There's got to be air in all the airways. They just can't be empty. So only a small proportion of what we're inhaling is actually participating in the exchange of gases, which I think is kind of interesting. But when only your tidal breath occupies your lungs, there's room for additional air that can be inhaled. So this is normal, quiet inspiration and expiration, just our little air going in and out all the time. So the inspiration that's in excess, that's of what's used in tidal breathing, is the inspiratory reserve volume. So it's the volume of air that can be expired when needed, but it's usually kept in reserve. So hopefully that kind of makes sense. The volume of air that can be exhaled in excess of tidal breathing is called the expiratory reserve volume. So the lungs are never completely emptied of air, even after maximally exhaling the expiratory reserve volume. The volume of air within the lungs when the expiratory reserve volume has been exhaled is called the residual volume. So that's always in there. Or, it can't be empty. It can't be a vacuum. Your alveoli would collapse, and that would stink, because we all know what happens when your alveoli collapse. Bad things happen. So the sum of two or more volumes is referred to as a capacity. So the tidal volume plus, and this is the chart from the O'Sullivan book on page 435 in the 7th edition. If you have the 6th edition, I don't know what page it's on. But so the tidal volume plus the inspiratory volume is the inspiratory capacity. And all of them have little acronyms. So IC is inspiratory capacity. So tidal volume plus inspiratory reserve is inspiratory capacity. So that's the volume of air that can be inspired beginning from a tidal exhalation. So you get normal exhalation and then the maximum amount you can bring in. So hopefully that makes sense. The combination of residual volume and expiratory reserve volume is the functional residual capacity. So functional residual capacity is the volume of the air that remains in the lungs at the end of a normal, relaxed tidal exhalation. Okay. The sum of the inspiratory reserve volume, the tidal volume, and the expiratory reserve volume is called the vital capacity. It's all of the possible volume of air within the lungs that's under volitional control, meaning you can deliberately exhale it out and you can deliberately inhale the maximum amount in. That's your vital capacity. We still have that reserve volume that's going to stay in there. We can't exhale it out and collapse our lungs. That would be bad. We don't want to do that. So the common method of measuring vital capacity is to achieve maximum inspiration and then forcibly exhale as hard and fast as possible into the measuring device until the expiratory reserve volume has been exhausted. So this is a forced expiratory maneuver, so it's called forced vital capacity. If you've ever taken a breathing test, that's what you do. You inhale as much as you can and you blow out as hard and as much as you can into the machine. And when they're testing you for all sorts of different respiratory things, that's the measurement that they do. So all the measurements that they do, that's a way of evaluating. That is not usually done. That is not ever done in a PT clinic, unless maybe you work in some really unusual facility where you're specializing in pulmonary facilities. And in places like big places like Cleveland and Atlanta and probably Seattle, I don't know, might have these specialty hospitals. But if you live in a smaller city or work in small town USA, you're not going to have that stuff. And you're probably not going to be working in that type of facility where you have that. But regular doctors' offices do have the capacity to test these things, and they'll test people for asthma and that sort of thing. So there's certain values of these that will indicate that you have certain disorders like asthma or whatever. So this is just the flat out definition of each one of those. Total lung capacity is the total volume of air in the lungs after maximal aspiration, and that includes all the volumes. Tidal volume is the amount going in and out with each normal non-forced breath. The inspiratory reserve volume is the maximum amount of air that can be inhaled in excess of normal quiet inspiration. So your normal tidal volume, and then you inhale more. Expiratory reserve volume is the maximum air expired following a passive expiration. So you passively just let your air go out, and then you exhale as much as you can after that. The residual volume is the amount of air that remains in the lungs after forced expiration. That's the stuff that's always there, so your lungs don't collapse. Inspiratory capacity, and remember, capacity is a combination of volumes. It's the maximum volume of air that can be inspired after reaching the end of a normal quiet expiration. So it's the sum of the tidal volume, that's your normal quiet expiration, and the inspiratory reserve volume. Functional reserve capacity is the volume remaining in the lungs after normal passive exhalation. So that's going to be your reserve plus a little. And the vital capacity is the maximal amount of air expired following a maximal inspiration. So that's like really, that's kind of where the rubber hits the road. That your vital capacity, that's what your lungs are capable of. So hopefully that all makes just tons of sense, right? So who's the patient population that we're working with pulmonary PT? People with chronic obstructive lung diseases like COPD, emphysema, bronchitis, bronchiectasis, chronic asthma, cystic fibrosis. People with restrictive lung diseases like idiopathic pulmonary fibrosis, sarcoidosis, rheumatoid lung, post-acute respiratory distress syndrome, people who have structural or iatrogenic restrictive lung issues. Things like restrictive lung diseases also include things like inhaled pneumococ. I can't say that word. I'll say it later. Like asbestosis and farmer's lung and that kind of stuff. Lung cancer, pre and post-op treatment, pre and post lung transplant, pulmonary hypertension, or any preoperative patient with lung disease comorbidity. So I've definitely in acute care worked with a lot of people pre and post lung transplants and people with COPD exacerbations. So they're, but then I'll talk to you a little bit about kind of when you're going to be doing this. If you work in a hospital, relatively large hospital, probably a lot of what we consider pulmonary therapy is going to be done by licensed respiratory therapists. So if you live in small town USA or wherever, and there aren't any licensed respiratory therapists, or there aren't very many of them, you may be doing more pulmonary therapy. Or if you work in a hospital that has a big pulmonary recovery center, you might be doing more. So you'll just have to take that under advisement. So the obstructive lung diseases that we're mostly going to be seeing in pulmonary therapy include cystic fibrosis, and the obstructions are caused from thick mucus. Lung cancer, the obstructions are from space invading structures like tumors. Aspiration, obstructions from foreign objects, solid or liquid, and asthma, obstructions from hyperresponsive airways. And then, of course, so all of those are considered COPD, obstructive lung disorders. So in a normal lung, all the volumes and capacities that we talked about are, as I said, in an obstructive lung, you have decreased vital capacity, decreased inspiratory and expiratory reserve volume, and you have increased total reserve volume. So you're not breathing out as effectively or in as effectively, and so you have more stale air trapped in your lungs, if you want to think of it that way, and you have less functional reserve capacity and less total lung capacity. So obstructive lung disorders make it hard to breathe. That's the fancy way of saying that. So normal lung versus an obstructive lung, in a normal lung, the vital capacity is more of the total lung capacity. In an obstructive lung, the vital capacity is less of the total lung capacity, so you have less vital capacity. That's the real upshot of obstructive lung disorders, less vital capacity. You just don't have as much leeway in what you can do and still be able to breathe. So that's going to affect your functional mobility. And we'll talk about how. So I've got to say, I'm not crazy about this slide because I feel like it's labeling. And I don't like to label people with things like this, but it's a way of remembering like what you're going to see with COPD presentations. So either like reddish tinge to the skin, and that's the CO2. They're holding more CO2. They're not expiring very well. The hunched over posture to use the accessory muscles more, really developed accessory muscles because they're using the accessory muscles more, and kind of that flattened barrel chest look. The pulmonary obstruction is the cyanotic look, the bluish look. The more pulmonary edema type look, the kind of bloated look. So the other thing that you won't be able to see with your eyes, but you can test diaphragmatic capacity, and you can see it in imaging and stuff. People with COPD have a flattened diaphragm and a barrel-chested thorax and a protruding abdomen because they're using kind of more of their abdomen as accessory muscles to breathe, as well as those ones that attach to the ribs. So the impairments that we see in COPD patients have weak muscles, all of them, not just their breathing muscles. They have weak muscles because of systemic steroid therapy, reduction in type 1 or slow twitch endurance fiber proportion in their muscles, increased reliance on anaerobic metabolism because they're lacking oxygen, so they have to use anaerobic metabolism. So these people are in a state of acidosis a lot of times. Decreased concentrations of oxidative enzymes in the quadriceps femoris, that's from results of studies, meaning it's harder for them to do things with their muscles. And increased fatigability because of that reduced muscle mass. Their functional impairments usually include lower scores for elderly COPD patients, including the 3 tests on the short physical performance battery, the SPPB, balance, gait speed, and sit to stand tests, reduced 6-minute walk test, an average of 52% as compared to predicted normal values. So they have functional impairments. The opposite end of obstructive is restrictive respiratory disorders. So pneumoconioses, that's the word I couldn't say earlier, related to extrinsic irritants like asbestos or silica, whatever. And structural or functional disorders, disorders of inhalation or compression of respiratory structures. So those are the restrictive respiratory disorders. The impairments of restrictive lung disease patients, they have significant dyspnea and hypoxemia. So lots of difficulty breathing and low oxygen levels. They have cardiovascular limitations, anxiety and depression. That sort of makes sense, doesn't it? If you're hypoxic, that leads to anxiety. Ventilatory muscle weakness and skeletal muscle dysfunction and weakness, just like the obstructive disease people. Okay, so in the next section, we're going to talk about techniques.